let's start. It's my great pleasure to introduce Dr. Richard Barron. Rich, would you introduce yourself?
Thanks, Ruth. It's a pleasure to be here with you. And once again at the Aspen Institute, I am the CEO of the American Board of Internal Medicine and the ABIM Foundation. We're the certifying board that certifies 1 in 4 doctors in the country when you hear the expression board certified. And I have the privilege of serving on the Aspen Institute Health Strategy Group, which you have led so ably over the years.
And you're also a practicing physician.
I spent 30 years.
You haven't given up your practice.
Well, sadly, I spent 30 years in community practice a few blocks from where I live in the Mount Airy section of Philadelphia. But I did have to give up my practice when I joined the government. And now I precept residents a half a day every couple of weeks. So I still do a little bit of patient care, but I am not the practicing doctor that I used to be.
But you're an expert on the topic that we're here today to discuss. Lots of experience.
I certainly have that.
Absolutely. So with that, let me start out. I think you're going to agree with this. There are a number of factors that determine health outcomes besides having a medical insurance card or having access to quality health care. Physical, economic, social environments all play a role, as does behavior or personal choice. But I think one of the lessons we've all learned through the pandemic experience is that trust is also one of those factors. Unfortunately, however, like so many other national institutions, we seem to have lost trust across the healthcare ecosystem, ranging from basic science, look at what happened with vaccines, basic science to our healthcare leaders, look at what happened with Tony Fauci, and from our hospitals and other providers to healthcare companies themselves. In turn, this lack of trust or loss of trust, I think, has had and will continue to have an impact, a detrimental impact on health outcomes. You're a member, you just mentioned, of the Institute's Aspen Health Strategy Group. You are the leader of the American Board of Internal Medicine, which has had this initiative for a number of years, building trust. You're a real expert, as I said, on this topic. So before we get into what might we do to improve the situation, let me just step back and say, where exactly are we on the trust barometer? And wherever we are, how did we get here?
Well, we're not in a great place in the trust barometer. And if you go back to the late 60s, medicine was one of the most trusted institutions in the country. We are the biggest loser on the Gallup Trust Barometer, having gone from confidence in the mid-70s to confidence in the low 30s, high 20s. 1 in 4 Americans is telling Gallup that they don't have confidence in the healthcare system. And we've really lost a lot in the last 50 years. Last 5 or 10, there was a little bit of a spike in favorable trust during COVID in 2020. But over the last year or two, it's back down again. And at this point, more people tell Gallup they have they do not have confidence in the healthcare system than tell them that they do.
So this is not a new problem. It's been around for some time. It seems to have gotten worse, even though maybe we did a little bit better. What do you think is behind this loss of trust? Because you're right. As a kid, we lined up to get our shots. Our parents didn't question what our doctors and healthcare system said, this is what you need to do. Now we question virtually everything associated with it.
You can't get away from the fact that there is a broad attack on expertise in the culture. Mm-hmm. That anybody who puts themselves forward as an expert, any claim of expertise is regarded as, there go those elites trying to boss me around. They have their interest at heart, not my interest at heart. I need to protect myself. And that is very broad. And of course, lots of institutions have what we refer to in the foundation work that we do as earned mistrust. So if you look at health equity as an issue, for example, if you're a person of color, you can talk about historical examples of poor treatment of people of color. You can talk about the study of untreated syphilis in Black men done at Tuskegee. Mm-hmm. You can talk about Henrietta Lacks at Hopkins. And of course, at the Health Strategy Group, you brought the descendants of Henrietta Lacks to talk to us.
And for those who might not be familiar with that particular case, this was a woman who, unbeknownst to her, took her cells, used them without her consent, without her understanding what they were even doing. Of course, the use of that cells has been one of the most important tools that we've had in medicine. But this took place without her knowing, and there's been a lot of history behind it now that has, like the case of Tuskegee, that has caused legitimate concern among some communities.
That's right. Yeah. And so you have these historical examples that cause legitimate concern. But then if you look at current trends and you look at health equity and you look at disparities, if you're a person of color, that's telling you, you know what, it's still happening. You know what, it's still true. The healthcare system is still not meeting my needs, not caring for people who look like me. So people who bring that experience into the exam room, much more skeptical, much more apprehensive. The fundamental question, is the doctor recommending this for me or for herself? Which is it? And that has really eroded trust. There are lots of ways that the healthcare delivery system has behaved to earn mistrust. One is we know that there are challenges with quality and safety across the country in healthcare. So patients can say, I can't really count on getting through this surgery without something bad happening. So that's a basis for it. We know that healthcare has become increasingly more expensive, unaffordable. We know that healthcare charges are the largest cause of personal bankruptcy in the United States. Exactly. It's not unreasonable for someone who's filing a personal bankruptcy because of healthcare bills to say, they're not in this for me, they're in this for them. That's a very reasonable thing for people to say. So I think there are lots of ways that healthcare institutions, without intending to, behave in ways that generate mistrust. And at the point at which you don't have trust, you don't believe what people are saying, and you start to listen to other people with whom you might have some other relationship besides that they're experts.
So this is a problem not just between doctors and patients, but within the big system itself, across the board.
Absolutely.
Hospitals, companies, whatever.
Absolutely.
Your insurance company.
Absolutely. And I think that many doctors and healthcare leaders start with the proposition of, I go to work to take care of patients. I'm self-sacrificing to take care of patients. Every day I went to work in my community practice, I really said, I'm putting myself out there to help my patients. It didn't occur to me that my patients would doubt that because of the purity of my intention. What I didn't realize was all the history that they're bringing into the room, all the ways that institutions have behaved that generate mistrust, and the way in which I had, from the moment I would meet a new patient, a steep hill to climb to earn that trust, not to mention experiences they might have had with other doctors that didn't go so well. So I think we need a lot of recognition within the healthcare system that we can't just presume that we're going to be trusted because we think we have good intentions and because we have great science. That's, I think, the other thing that gets us in trouble is we think that authority and legitimacy come from that expertise. That because we're using rigorous scientific methods, we think that's why patients will trust us. But actually, trust is built from a whole series of human interactions that have nothing to do with randomized controlled trials. And at the point at which people start wondering whether you have their interest at heart or your interest at heart, people will distrust and they will be susceptible to misinformation and they will say, why should I believe you? And I think a lot of the government's problem is that the government has failed many people. They feel left behind. They feel not cared for. They feel not focused on. And then it's like, well, why should I listen to Tony Fauci? Why should I listen to CDC? They're not going to tell me, they haven't helped me before. Why would they help me now?
Credentials alone are not enough.
That's correct.
Got it. So what do we do? How do we regain trust, doctor-patient, but within the healthcare system as well? It's a tough question, but what are some of the things that we might be able to do to address this problem that is, in my own view, this whole mistrust thing, not just in healthcare, but across our many institutions, it's one of the biggest problems we face as a country, and it's not going away.
Oh, I completely agree. And I think that the first steps that people in healthcare leadership need to take is some amount of humility and some amount of recognition that they can't just presume that people trust them, and they have to actively focus on trust-building strategies. And that can happen at the micro level, at the doctor-patient level. I had a friend who tricked his medical record that he put on the landing page how to pronounce the name of a difficult patient. And he described meeting the guy the first time. The guy puts out his hand. He says, "My name's Chuck Sheedle, rhymes with needle." And my friend says, "What's he telling me? He's telling me that people have been mispronouncing his name all his life. He's going to give me a chance to fix that." Well, one of the ways we can use technology in healthcare is to carry that forward so everyone who interacts with him will know how to pronounce his name. We often don't think about using technology that way. We've got teams focused on using technology to meet quality metrics or revenue cycle management or any number of things that people use technology for. We're not thinking of technology reliably as a trust-building tool, but there are a variety of ways we could use it to do that. So I think that's one strategy. Another strategy that institutions can use is drive an institutional level focus on trust. So Parkland Hospital in Dallas did a trust practice challenge where they invited all the departments in Parkland to nominate something they were doing in that department that they would say, we think when we do this, we're building trust. That kind of thing, first of all, elevated people's efforts around trust, caused the entire hospital staff to focus on and think about what are our opportunities for building trust, gave management an opportunity to recognize and feature trust-building activities and highlight them. And they put together a beautiful book of things that were nominated for this. And I think that's another strategy to try to generate institutional focus. We have, all of us in our institutions have management meetings. What are they talking about? They're talking about market share, bed occupancy, patient flow. Could they devote one of those meetings to what could we do to build trust with the people we serve? At the American Board of Internal Medicine, we had that conversation across a variety of our governance groups, and a consistent theme emerged. We could do a better job engaging early career physicians in the work we do. And then we wound up adopting a requirement that each of our governance structures needed to have at least one early career physician on it. So you can get from a discussion about trust at a leadership level, at a management level, you can generate ideas that you really can bring into practice. If you never have the conversation, the ideas don't even make it to consideration.
Exactly. You gave the example of what's happening at Parkland Hospital in Dallas. Are there other examples that we could look to where trust is at least being rebuilt? Be terrific if they're there, but at least they're in the process of getting there?
Absolutely. Earlier, when we were talking about our meeting with the lax descendants at the Aspen Institute Health Strategy Group, that was a gesture to a group of people that said, we're going to talk about your grandmother, I think it was their grandmother, right?
Yes.
We're going to talk about your grandmother. We're not going to do that without you here. And one of the things they told us was that NIH, which made major use of the HeLa cells that came from Henrietta Lacks, now gave them representation on committees that NIH has. That's an example of an institution looking at its own history, looking for opportunities to rehabilitate itself, looking to have an honest conversation with people who may have been injured by untrustworthy behavior. Another example is the Milbank Foundation, which discovered, looking at its own history, that it had funded part of the study done in Tuskegee on untreated syphilis. And they realized they needed to make a public apology for that. And the way they did it was they contacted descendants of the men in the study, met with them in Tuskegee, apologized publicly to them and the world for having funded this study, and then engaged in a conversation with the descendants of what would it look like to make you whole. Because apology is pretty basic. It's what we do when we injure other people. Institutions can do that too. So I think there are examples of institutions reckoning with their past, honestly, being transparent about it, and trying to take steps to put things right.
Is there anything, don't mean to put you on the spot on this one, is there, some of these strategies are going to take a while. We are not going to fix this overnight. Is there anything we could do, sort of low-hanging fruit, that we could, in a relatively short term, begin to see that trust reemerge? Other than you've suggested teams coming together and having the very discussion. I mean, that obviously we can do that. Is there anything else?
I think that every opportunity that a healthcare delivery system, a clinician, every opportunity in which they're interacting with a patient, there are huge opportunities for trust building there. So that, for example, I talked earlier about using technology to get name pronunciation right. Well, a patient may come to a visit and say, my daughter's getting married this weekend. When they come back in 3 months, if whoever it is who sees them says, how was the wedding? That's huge. Patients want to be recognized. They want to be known. They want to feel like the people who are taking care of them know them. And again, if you look
And are listening to them.
are listening to them, exactly, are listening to them. And if you look at some of the examples in the way technology manages this, Amazon knows you. They know what you're going to want. They know where you're going to want to ship it. They know how you're going to want to pay for it. They're using technology to give you an experience of being recognized. We don't do that so well in healthcare, but I think if individuals in healthcare think of every opportunity they have interacting with a patient as an opportunity to build trust, I think you get a very different picture, even if it's the first 10 seconds of an encounter. That's really where we have those opportunities, and I think we squander them routinely in healthcare. And I think there's many ways you could go deeper with that. You could go deeper administratively, you could go deeper educationally, you could go deeper technologically. But I think fundamentally, if everyone in healthcare sees every opportunity in which they're interacting with a patient as an opportunity to either gain or lose trust, I think we would move very quickly in a direction of generating more trust.
Terrific. Dr. Richard Barron, told you he's an expert. Can't do any better than that. Thanks
Pleasure.
very much.
Thank you, Ruth, for inviting me to do this, and thanks for all the work you do with the Health Strategy Group.
Terrific.